So, are you guys able to see it now? Clear? Hello?
Yes,
Hello?
sir.
Okay. So, we are dealing with a complex topic, acute kidney injury. Why is it complex? Because we get to see many patients with acute kidney injury. The only problem is that we are not able to methodically come to a diagnosis as to etiology, and therefore we are delayed in terms of management. So we'll start with the basic definition. The definition is basically an increase in serum creatinine from the baseline by about zero point 0.3 milligrams per deciliter within 48 hours. So if you had a patient with serum creatinine of 1.1, and in the same laboratory after 2 days, there is a creatinine which has jumped up to 1.4, theoretically that this is acute kidney injury. Okay. And an increase in serum creatinine more than 1.5 times the baseline, which was known or presumed to have occurred within past 7 days. Urine volume, this is very important. So there are three aspects of definition, and a urine volume of less than 0.5 ml per kg per hour for 6 hours. So if you roughly calculate a 60 kg patient, it would come out to be 30 ml per kg. So 30 ml, 60 ml ka half, and that is around 630 ml per hour. For 6 hours, it comes out to 180. That is around 200. So anybody who hasn't passed urine enough, more than 200 ml in the last 6 hours, is a patient who fits into the definition of acute kidney injury. Now, we in our clinical practice, what do you call, look at serum creatinine as a perfect parameter, but then it isn't so, because serum creatinine is dependent upon certain intrarenal factors which increase the creatinine in spite of GFR not going down. So some drugs, as I'll give you the names, trimethoprim, etc., decrease the excretion of serum creatinine into the kidneys, mm, into the tubules, and therefore can cause a slight false elevation of serum creatinine in spite of GFR being normal. Non-renal factors like weight. So again, you have to be very cautious. 1.2 creatinine. So we always look at zero point 0.6 to 1.2 milligrams per deciliter as the normal range. But it depends upon total body mass also. So a 100 kg bodybuilder may have 1.4 or 1.5 creatinine, which is perfectly normal because of his muscle mass. On the other hand, even 1.2 serum creatinine in a 70-year-old male or maybe 70-year-old female is quite a severe derangement. This is something that you must keep in mind. You cannot look at the parameter alone. You have to look at the size of the patient as well, size and body composition. Then the third point is that serum creatinine, what we are using basically to estimate GFR. Now, this GFR that we calculate is only in steady state. So, in steady state, as in the patient's renal function is steady over a period of more than 3 days. Then only serum creatinine can be used to see whether GFR, to calculate GFR. If suppose the patient is having an acute kidney injury and the GFR is falling acutely, let's say a patient was there who had serum creatinine of 1.1. He started having 5 or 6 episodes of diarrhea. In each of these diarrheal episodes, he was losing 1.5, 150 ml of water, 150 to 200 ml. So 1 liter of water he has already lost, because of which the creatinine has increased from 1.2 to 1.6 or 1.7. Now, in the last 4 or 5 hours, patient has not passed urine. So what is his eGFR? Any answers? Zero, na? He's not passed any urine in the last 6 hours because of dehydration. But if you calculate using that 1.7 creat from 1.2, which jumped up, the GFR will come out to be 30 or 40, which is falsely high. Therefore, you can only calculate eGFR in a chronic kidney disease, but you can never calculate eGFR in acute kidney injury. Therefore, when you adjust the dosages of drugs, you must assume GFR to be less than 10 ml when you adjust the dosages of drugs in acute kidney injury. Whereas in CKD, you can adjust as per their EGFR. Okay. Then comes lab variations. Well, different laboratories have different methods of estimating creatinine and different standards. So, because of which there can be a variation in one lab versus the other. So, this is frequent, especially when a patient is shifted from one hospital to another. In that hospital, the creatinine was 1.4, and your hospital it is 1.9. It's probably because of the different laboratories. That's why, whenever you are following up these sort of patients, you should insist on the same lab. Whichever lab you choose, keep using the same lab so that you can estimate the creatinine better. What are the drugs which increase the serum creatinine? Well, by inhibition of creatinine secretion, trimethoprim, sulfamethoxazole, you know that Septran is very famous drug. Cimetidine almost nobody uses. Increased serum creatinine due to interference with creatinine measurement is ascorbic acid. Again, something which is used in COVID-19 a lot, and people are even using IV ascorbic acid. So this can cause an interference. Cephalosporins, fluocytosine, ketosis. Now, in ketosis, you may overestimate the creatinine. Falsely low creatinine due to interference with creatinine. So, whenever bilirubin is high, you may get a lower than normal value. And of course, enhanced creatinine in meat eaters. Okay. This is a famous formula, Cockcroft-Gault formula. I don't want you to remember it. If you can remember it, it's great. But it's important. Serum creatinine is used as a surrogate to measure the GFR, glomerular filtration rate. Now, what does this depend upon? It depends upon the age of the patient. It depends upon the lean body weight in kgs. It depends upon serum creatinine. And in females, you have to multiply a correction factor of 0.85. If it is an Afro-American, I guess the correction factor is 1.21. So it's clear that it depends upon the lean body weight in kg, not the total body weight. So you are actually trying to look at the muscle mass rather than the total body weight. Okay. Second thing is, as you grow older, the GFR drops because the number of functioning nephrons drop. Okay. And of course, females have lower than males as far as GFR is concerned. This is the MDRD formula. It's extremely complex. There are calculators available. There's one CKD EPI formula as well, which can be used to estimate GFR. Now, these are the two criterion to diagnose and classify acute kidney injury. The rifle criteria. Rifle stands for risk, injury, failure, loss, ESRD. The first three are within the first 48 hours, and loss and ESRD is the later on consequence of acute kidney injury. So if creatinine is only increased to 1.5 times of its baseline, then it is risk alone. Okay, GFR is falling by 25% of the baseline. If it is increased by 2 times the baseline or GFR falls by 50%, then there is an acute kidney injury. Renal failure is classified as somebody who has 3 times an increase over the baseline of 4 milligrams per deciliter creatinine, or an acute rise by 0.5 milligrams per deciliter. And GFR has fallen by 75%. Complete loss of kidney function for more than 4 weeks is loss, and if it exceeds more than 3 months, these patients are having ESRD. Now, it is very important. Earlier, it was thought that acute kidney injury, when treated, recovers. But then later on, people found out that if acute kidney injuries, there are some is severe enough, it may lead to chronic kidney disease or end-stage renal disease. And we will see in this presentation which subset of patients worsen, progress, and become ESRD. So that is why you have to be very careful and proactive in dealing with these patients. The other classification is very simple. It is based on creatinine only and the duration in terms of number of hours. Okay, so pen, laser point. Okay, so you can see. Can you see the pointer in your screens? Hello? Hello?
Yes.
Till now, it is clear now how to classify and stage acute kidney injury. There are three stages: stage 1, stage 2, stage 3. 1.5 to 2-fold increase is stage 1, 2 to 3-fold increase is stage 2, and more than 3-fold increase is stage 3. What are these stages based on? They are based on mortality. If you have 100 patients with stage 1, only 1.5 to 2% patients will die. If you have 100 patients with stage 2, then 5 to 8% patients die. Whereas in stage 3, around 15% patients die. If you have sepsis and any of this, 50% patients will die. So this is to prognosticate. Understand what will happen to the patient. Okay, so the first thing that comes to our mind is whenever a patient comes with increased creatinine, how to distinguish AKI from CKD. Most important do it is look at the case records to look for previous creatinine. So Mr. X comes to me with fever and his creatinine is 2.1. X has been a diabetic for 10 years. I believe that being a diabetic for 10 years, he has a risk that he was having a baseline kidney function which was then, yes, I look into his previous papers. 3 months ago, he had been operated for appendicectomy. Prior to his surgery, the creatinine was 1.6 or 1.7. So I now know that he had an underlying CKD or diabetic kidney disease, over and above which there has been an acute insult. So this is an AKI or CKD. However, there could be a case where Mr. X's was zero point 0.9 and therefore it is not acute kidney injury. It's not CKD at. Second is a anemia. We know that chronic kidney disease is associated with anemia because kidney has got endocrine functions. There are two endocrine functions of the kidney. One is to act in the activation of vitamin D, and second one is in the secretion of erythropoietin. Now, what happens is erythropoietin secretion decreases, as a result of which iron, although iron is there, it is not incorporated into the RBCs and you get normocytic normochromic anemia. Now it's very important at what level of EGFR does anemia manifest? Well, EGFR below 30, anemia is present in more than 80% patients. Okay, the only exception is ADPKD, where mysteriously anemia is not seen. In acute kidney injury, on the other hand, you should not get anemia unless it is the hemolytic uremic syndrome or thrombotic thrombocytopenic purpura. HUSTTP is the only variant of acute kidney injury where you can see anemia. Obviously, anemia can be a red herring, as in it can be there pre-existing in the patient, but no one investigation is going to allow you to make the distinction. You have to make use of previous records, presence of anemia, and sudden decrease in urine output. So you ask the patient whether he has a sudden decrease in urine output in the last 48 hours. If he says yes, again you know that there's an acute kidney injury. Last but not the least is ultrasound. Very important point is both acute kidney injury and chronic kidney disease, you can get an increased echogenicity. But cortical thinning is there. Thin cortex means destroyed cortex is seen in chronic kidney disease, and renal size is seen, increase in renal size is seen in chronic kidney disease. So normal kidney is around 9 to 11 centimeters and fall below 8 centimeters favors a CKD. Again, you have to keep in mind that a 70-year-old with 8.1 with preserved cortical dimension is not CKD. So these variations you have to account for as you get more and more experience. But broadly speaking, anybody with 7.5, 7.6, 7.3 kidney size on ultrasound is chronic disease. Okay. Now, acute kidney injury can be classified into pre-renal, renal, post-renal. So the first question that we always answer in a patient with increased creatinine is whether it's acute kidney injury or chronic kidney disease. Once you have established that it is acute kidney injury, you need to know whether it is pre-renal, intrinsic renal, or post-renal because the management strategies are completely different. Well, pre-renal is associated, basically, it's very simple. The kidneys are absolutely normal. It is just that kidneys are not getting enough blood. That is why there is a problem and creatinine has gone up. Now there is one very important concept to remember. Sodium and BUN, blood urea nitrogen, behave alike, and creatinine behaves a bit differently. Creatinine needs to be actively excreted by the tubules, whereas sodium is actively reabsorbed, but there is some amount of passive reabsorption as well. And the last but not the least is that BUN is completely passively reabsorbed, the nitrogen. Therefore, whenever there is a pre-renal cause, as in there is a depletion of fluid in the body starts avidly and whereas creatinine, although also creatinine excretion in urine is decreased, but it is not decreased in that proportion. As a result of which, BUN rises much more than creatinine. So if the BUN rises much more than creatinine, then it is pre-renal because body is avidly trying to reabsorb the urea. Whereas in a problem with tubules, the BUN and creatinine will go hand in hand because tubules are unable to secrete creatinine. 90% of the creatinine secreted by the tubules in human. Therefore, if tubular dysfunction occurs, there rise in creatinine, and this creatinine rise will be much more as compared to the pre-renal cause. So this is very important to understand. Also, because tubules are the center of reabsorbing sodium, sodium will not be reabsorbed and excess loss in the urine. Why am I telling you this? Because there are two ways of distinguishing pre-renal and intrinsic renal. One is by history, the second is by lab parameters. If you understand this concept, then be able to understand the table that will be coming next about how to distinguish pre-renal and intrinsic renal trouble based on lab parameters alone. Post-renal generally is relatively easy to diagnose. Renal stone disease has typical pain, which has been there for last 3 months. You know that there's an old person who has prostatism like symptoms. You know that an OBGY surgery was done, hysterectomy was done, and then the urine output has get decreased. You know that there might have been an injury to both ureters or one ureter. And finally, you know that in malignancies, especially cervical malignancies, uterine malignancies, if you have read the FIGO classification, they can involve ureters and incarcerate them, and therefore that can lead to a decrease in urine output. So post-renal are relatively easy. However, post-renal needs to be tackled quickly. If you do not relieve the obstruction in the ureter or at the level of bladder or at the level of prostate or ureteric stricture, then because of the pressure, the tubules atrophy, and finally the damage, intrinsic renal damage occurs. So, if it is pre-renal and neglected, intrinsic renal damage will happen. If it is post-renal and neglected, again intrinsic renal damage will occur. That is why whenever a patient with increased creatinine comes, you must do a screening ultrasound of the kidneys as well as urinary bladder and ureters because be able to out stones. You can see if suppose your radiologist doesn't want to is not free, you can do an X-ray erect kidney urinary bladder based on the simple philosophy that 90% of urinary stones are red opaque. So you will be at least be able to see the stones well. Okay. So as far as pre-renal goes, pre-renal is very simple. It is a decrease. There are two types of pre-renal. One in which both the total body water is also decreased and the blood which is going to the kidney is also decreased. So it could be due to GI loss, it could be due to diabetic ketoacidosis. It could be due to third space loss. There is one more type wherein which the total body water may be increased and yet the kidneys are not getting enough blood. Why? Because most of this body water is in extra vascular compartment, not within the vessels. It's outside the vessels. So you can have in heart failure, all the water seeps out and is there in the legs only. And this water is not considered that volume depletion of the actual blood which is going to the kidneys, and therefore your creatinine may have risen. So why is it important? Treatment of pre-renal with decreased total body water depletion is very simple. You give fluids. But in heart failure, with increased total body water, if you give more fluids, it's going to cause more pedal edema. So, in heart failure, you have to make sure that you increase better, make the pump function better, make sure that the medications which are causing exudation, transudation of fluid in the legs are decreased. And when you do that, the kidney function will return. So, and one more thing is most cardiac medications increase creatinine. So that is unfortunately the tussle between cardiologist and the nephrologist. Pancreatitis and burns are two special circumstances. We know that skin is a very good insulator and skin protects us from dehydration. When there is a loss of skin, epidermis into burns, there is a profuse loss of fluid, and hypovolemia and dyselectrolytemia is the main cause, and sepsis are the three main causes of death in patients of burns. Pancreatitis again can cause pancreatitis and peritonitis can cause third space loss, as in exudation of fluid outside the vascular compartment. Severe hypoalbuminemia that you see in patients who have been on chronic steroids or in ICU is one of the predominant causes of acute kidney injury, which is not addressed by our intensivist. They keep asking for nephro reference, this reference, that reference. That is not going to solve the problem. Replenish the albumin, move the fluid which is there in the interstitium inside the vessels. Kidney perfusion will improve and the kidneys will start pouring out urine. There is no magic wand in nephrologist's hands. There are only three things that are important that you will come to know: correct use of fluids, correct use of diuretics, avoid nephrotoxic drugs, and in certain cases use renal replacement therapy. There are some special diseases where you use immunomodulation. We'll come to that. So this basically deals with pre-renal. Intrinsic renals I have dealt with. Actually, as we go further, large vessel, small vessel, glomerulus, interstitium, and tubules. These are the five components of the kidney, and these all can be afflicted by different diseases. So we will go through it one by one. We there is nothing much to talk about in post renal, mostly a surgical problem. Just identify it early and refer it to a urologist. Now this is clear. One very important point that I missed out in pre-renal is overuse of diuretics. Remember that many patients are on diuretics for various reasons. Because of a chronic kidney disease, sometimes diuretics are prescribed. All heart failure patients are on diuretics. Some valvular heart disease like mitral stenosis, aortic stenosis are on diuretics with dyspnea. Now, what happens is when you give too much diuretics, because even in heart failure, you need to optimize diuretics. If you give too much diuretics, you'll cause dryness even in a heart failure patient, and that also can lead to increased creatinine. So there are two crazy reasons. Whenever a heart failure patient comes to us, pehle ka echo is 30%. The junior registrar presents to us, sir, creatinine is 30%, patient's creatinine is up. So I ask a simple question: what is it due to? Is it due to decrease in diuretics? Is it due to increase in diuretics? If you examine the patient, there is pedal edema, there is what do you call breathlessness, there are creps, there is S3 which is auscultable, then you clearly know, and JVP is raised, you know that the patient's diuretics are lesser than what he needs. This might be due to the patient having a lot of salt, papada and all, everything, because of dietary indiscretion. That time you can increase the diuretics or add a sequential diuretic. Like if there is a loop diuretic, you can add a diuretic which thiazide like diuretic or thiazide diuretic or a spironolactone like diuretic. But there is another situation where in which the patient was absolutely fine. Patient has been given diuretics because echo shows 30%. Patient has been working hard. He is dehydrated. Diuretic dose has not been tapered, especially during Indian summers. And then the patient's creatinine can rise up. Echo will always reveal EF of 30%. These subset of patients, to decrease the diuretics, automatically creatinine will go back to normal. So how do you decide this? I told you the evidence of fluid overload right from head to toe. Puffed up eyes, what do you call JVP, which is raised. How is JVP measured? Don't need to go through all that 45 degrees and two scales, nothing. If the patient is sitting upright and between the two heads of sternocleidomastoid, you can see venous pulsations, that is negative pulsations, then JVP is raised. And if a patient is lying down flat and still you are not able to see pulsations between the two heads of sternocleidomastoid, JVP is reduced below normal. So the second patient is dry, the first patient is wet or having too much fluid. So this is a very simple way to distinguish the two of them. Okay, and you understand that a good physical examination will help you to choose the right treatment. If you increase the dose of diuretics in the dehydrated patient, his creatinine will go up further. If you stop the diuretics in a overhydrated patient, creatinine will go up because of renal venous congestion, which decreases GFR. Okay, so that is very important. Diabetic ketoacidosis, I told you, causes obligatory loss of fluid because a lot of ketone bodies are getting excreted. Ketone bodies are negatively charged. They will pull along with them sodium and potassium. With the sodium, with the potassium, with the ketone bodies, all are osmotically active. They cannot go alone. They will carry with them the fluids. And of course, third space. Are you understanding everything? Hello?
Yes, sir.
Okay.
Yes,
Now,
sir.
what are the clinical signs of pre-renal with decreased extracellular volume? Well, history is important. I told you, history alone makes you a clinician. History taking the most underrated aspect of clinical medicine. If you are good, if you spend 15 good minutes with the patient asking the history completely, your diagnosis is made in 80% of the patients. And the 10 to 20 that remain, well, in 16 to 17% of the patients, if you combine them with a keen physical examination, your diagnosis is made. Only 3% to 5% patients remain where you need additional investigations to make a diagnosis. So, acute axillary sweat, a recent reduction in body weight, orthostatic hypotension is very important, defined as a fall in this is a very sensitive marker of a decrease in intracellular volume. If the patient is having any kind of dehydration, you make him lie down, take his blood pressure, make him stand up, take his blood pressure. If there is more than 20 millimeter fall or the pulse rate rises more than 10 beats per minute, it is very sensitive to tell you that there is fluid depletion. People often tell me, sir, fluid volume normal hoga because BP is normal. BP is the last thing to fall. You can be dehydrated having a normal BP. Moreover, you don't know what the baseline blood pressure was. Somebody whose blood pressure was 150 and has come down to 110 because of dehydration, you will call him normal. Everybody is different. Third thing is tachycardia. You have to always look at the tongue and parched mucous membranes. And this is very useful. Tenting of the upper thorax skin. You just pinch the skin between fingers. If it raises up into a fold, it means that the patient is dehydrated. It is intracellular dehydration as well as interstitial dehydration. Then last is, I told you, jugular venous pressure, not visible when supine. Pre-renal with increased ECF volume, as I told you, heart failure, decompensated cardiogenic shock, pericardial effusion, tamponade, massive pulmonary embolism, peripheral vasodilatation. This happens in local anesthesia, okay, and general anesthesia. So you can, if the fluid, that's why anesthetists are always counting the number of fluids. Often enough, we get a call in the OT saying that the patient BP has fallen down and patient is having bradycardia, come quickly, CPR is needed. We go in, realize patient's heart is fine, IVC is just collapsed. It is just because of the lack of fluid that there is a vasovagal reaction, and that is why there is bradycardia. So understanding this is very important because again, if you label it as syncope, then you have to subject him to expensive investigation. Baba Holter karenge, was there a transient VT or not? if you understand the history properly, look into the papers properly, what amount of fluid was given, what kind of surgery was taking place, how much blood loss has occurred, you will be able to diagnose. Sepsis, because there is peripheral vasodilatation. Remember, whenever there is peripheral vasodilatation, there is renal vasoconstriction. Therefore, the kidneys do not get blood. Anaphylaxis, anesthesia, cirrhosis, and liver diseases. I would add one more to this list. Of inotropes in a patient which is not needing them. Many times in ICU, you will see patients with 110 blood pressure and still on NORAD, dopa. This needs to be discussed. Inotropes, inotropes and vasopressors have caused more harm than any benefit. None of the inotropes, none of the vasopressors have ever led to survival. And they are only used as they should only be used as last resort, and they should be quickly tapered ASAP. Because imagine a patient's BP is 110. You are using noradrenaline. Noradrenaline now is going to cause peripheral vasoconstriction. But now where all will it act? The body is very clever. It maintains the blood flow to the brain. The body is very clever that it maintains the blood flow to the heart. So which three organs ka blood flow suffers? Skin, and GI. And therefore, if you overuse noradrenaline, you are going to cause bowel ischemia. And when bowel is well perfused, it prevents gut translocation. Within the bowel wall, there is a lot of fecal matter which is rich in bacteria. Outside the bowel wall, the peritoneum is sterile. Why? Because there is a mechanism that body has made to defend it. As soon as there is ischemia, there is breach in mucosa, there is fall in immune cells. Guard this. There is going to be a gut translocation and secondary sepsis ensues and causes mortality. So how do we see these patients? Well, elevated jugular venous pressure. I told you in seated position, if you can see the venous pulsations, sometimes they are so high, especially in tricuspid regurgitation, that your ear lobules also start flickering. Ascites, lower extremity edema. Please look for lower extremity edema in every patient with deranged creatinine. ADHF can be identified by creps, pulmonary crackles, you auscultate. There is crackles, typical sound. You can Google it, and there are even apps where in which you can hear the crackles and practice it. The best is obviously bedside. S3 gallop. Again, it is nothing but a gallop rhythm. Like that. There will be tachycardia, and the two hard sounds ke baad, there will be a soft sound. So this is an S3 gallop. It is a very sensitive sign of left ventricular dysfunction. But you need to train your ears. Similarly, there is an S4 sound that you hear whenever there is patient who is having hypertension or aortic stenosis. Again, you have to train your ears. Liver failure may be identified by jaundice, decreased liver span. Again, you can percuss and find out the liver span. Palmar erythema, reddish palms, obviously history of alcoholism or viral hepatitis, and spider angiomas. Some drugs worsen pre-renal failure due to disruption of intrarenal hemodynamics. So what happens whenever there is dehydration? There is kidney senses dehydration, and there is a tubuloglomerular feedback and glomerulotubular balance. So what it does is it starts reabsorbing. Glomerulotubular balance is glomerular se kam se filter ho gaya. It starts essentially reabsorbing more fluid so that less amount of urine is produced. Because already dehydrated, if you produce a normal amount of urine, then you will be in trouble. And on the other hand, there is something called a tubuloglomerular feedback. If the tubules are sensing less amount of sodium being leaked out, then what it does is it starts secreting renin, which converts angiotensin 2 into angiotensin 1 into angiotensin 2. Angiotensin 2 contracts the outgoing arteries, but does not cause contraction of the constriction of the incoming artery. So, angiotensin 2 causes contraction of the incoming artery more than the outgoing artery, decreases GFR. Now, what happens is if this intrarenal, this is hampered by your ACE inhibitors, okay, and because of which this can lead to increase in creatinine. Again, NSAIDs, very important to ask history of NSAIDs. Many patients have aches and pains for which they are prescribed NSAIDs left, right, and center by everyone. orthopedicians, by general physician, by medicine, by rheumatologist. Ibuprofen, diclofenac, because intrarenal prostaglandins are used to adjust the afferent arteriolar tone and the peritubular network tone. If there is the use of NSAIDs, you will be in trouble. Same is the case with tacrolimus and cyclosporin. Although these drugs are used rarely, but you must keep it in mind. Now, this is a table which tells you how to distinguish pre-renal from intrinsic renal. The first one is very easy because I had explained it to you. Can anyone revise why is it that the BUN rises greater than creatinine in pre-renal? So, did anyone understand that concept? Okay. So I'll explain it back to
Hello.
you. Huh. Who was going to explain?
So you mentioned that the BUN is completely reabsorbed as compared to the creatinine. So essentially there wouldn't be.
Yeah. So creatinine is actively secreted by the tubules. Tubules are essentially normal in pre-renal failure. BUN is passively reabsorbed and avidly reabsorbed. Therefore, BUN rises in the blood. Creatinine continues to be excreted in the urine. So BUN disproportionately rises in terms of is compared to creatinine. So pre-renal will have raised creatinine, but BUN much more raised, and a BUN creatinine ratio more than 2:1 almost certainly is likely to be pre-renal. What is the caveat? There can be certain diseases where BUN is produced in excess, especially hypercatabolic states like sepsis. And next is steroids, because of which there is a more breakdown of proteins. So BUN can be very much higher than normal. And because of that, you may get a falsely elevated BUN creatinine ratio, although there is intrinsic renal damage. But that is a rare circumstance. Most circumstances, BUN creatinine ratio is more than 20:1. It is pre-renal. You give fluids, patient will come back to normal, especially if there is no cardiac ailment. If there is BUN creatinine ratio is less than 10:1, it is intrinsically likely. Again, I told you BUN is like sodium. Now, what happens is BUN is reabsorbed too much. Sodium is also reabsorbed because of aforementioned facts. I said that there is a glomerulotubular balance and tubuloglomerular feedback causes increased avid absorption of sodium whenever the amount of glomerular filtrate is less. That is why urinary sodium is less than 10, 20 milliequivalents per liter. And whereas intrinsic renal damage, I told you that sodium is absorbed through tubular cells. And if tubular cells are damaged, then there will be excretion of sodium in the urine. Now, then comes osmolality. Well, it's common sense or intuitive to say that whenever there is dehydration, patient will pass less urine. If less urine is passing, it is going to be more concentrated urine. That means it's going to contain more solutes, and therefore osmolality will be higher. This should be a sign of greater than 500. Whereas in intrinsic renal damage, the solute and all is just going to be akin to plasma osmolality, because the kidneys can neither secrete nor reabsorb. Plasma osmolality is around 300, so they'll be around 350. Okay. Urinary creatinine by plasma creatinine ratio, as I said, that urine creatinine will continue to be excreted because it's a tubular secretory process and tubules are functioning fine. So that ratio will be more than 40, whereas it will be less than 20 because tubules are needed to excrete the creatinine. And plasma creatinine would rise disproportionately high whenever there is an intrinsic renal damage. FENA is simple. Don't get confused by the formula. Simple rule of thumb is whenever there is excretion, whenever there is a pre-renal problem, the sodium is going to be more reabsorbed. Therefore, FENA is going to be less than 1%. Whereas whenever there is going to be an intrinsic renal problem, sodium is not going to be reabsorbed because it's reabsorbed by tubular cells. the FENA will be one. The only exception is diuretics, because diuretics selectively inhibit the reabsorption of sodium. And in a situation where diuretics are there and patient is having, you are having a dilemma of pre-renal or renal, then you use fractional excretion of nitrogen. Okay, urea nitrogen. If that is less, because urea nitrogen does not need tubular cells at all, it just goes paracellularly. If that is less than 35, that means urine is not containing enough amount of urea nitrogen, then the patient is pre-renal. Whereas if that is more than 50, then it is a problem with the kidneys. Okay. Most important is urine analysis. Every acute kidney injury should have urine analysis. So urine analysis is basically three parts. One is dipstick, which gives you immediate results. If you have seen your 7 is dipstick, it has got ketone bodies, it has got nitrites, it has got leukocyte esterase, it has got heme, and it's got proteins. So heme and proteins are very important. If heme is positive and proteins are positive, it's a problem within the kidney. Whereas there will never be proteinuria in a pre-renal disease. Physical affection, well, we will go into each one of them. Large renal vessels, small renal vessels, glomerulus, interstitium. Till now, do you have any doubts regarding pre-renal failure? Any doubts regarding pre-renal acute kidney injury? I think it has no doubts. Well, we start with large vessels. So renal artery thrombosis or renal vein thrombosis. This happens suddenly. It is often in a procoagulant state like antiphospholipid antibody syndrome, or you can get it in membranous glomerulonephritis. Patient is classically suffering from these diseases and comes to you and says, Doc, since morning I'm having severe pain in my loin region, flank pain, and I have not passed any amount of urine. Or little amount of urine is red and heme positive. There's hematuria. You immediately know that this is a problem with the, as far as renal artery thrombosis or bilateral renal venous thrombosis. You immediately do a renal ultrasound, especially Doppler, and you can find out the diagnosis. Do IgG, IgM, APLA, anti-beta 2 microglobulin to make a diagnosis of APLA. Membranous glomerulonephritis, well, once you have resolved the problem, then you can do a biopsy. Okay, rare, but you must be aware. Second is renal small vessel disease. Well, atherosclerotic disease is very common. So what happens is, whenever we manipulate the aorta, whether surgeons are doing it or cardiologists are doing it or any kind of surgery, aorta has plaque atherosclerotic debris plastered to it. That can get discharged and can go into the kidney. And whenever it goes into the kidneys, it's going to go down also. Na? Renal arteries are only arising from abdominal aorta. It will go down and cause purple toe syndrome, as in because it will get block the end arteries of the toes, and it will cause livido reticularis. That is, you can palpate the arteries of the limb, of course, the veins. Cholesterol emboli can go into the gut and pancreas through celiac circulation and cause abdominal pain, along with and raise increased creatinine, especially post CABG, post PCI, or even after thrombolysis. Very important is RBCs and granular cars are there in urine. Proteinuria is there, but it's only a mild proteinuria, less than 1 gram, and there might be eosinophils in urine. Now, eosinophils anytime in urine are rare. Don't find them, it does not mean that your diagnosis isn't right. But if you do find them, it establishes your diagnosis more. C2 complement C3 is less, C4 is normal. You can do a biopsy and you can see cholesterol in the feces. What is the treatment? No treatment. Just continue giving statins. Automatically, it recovers. HUS, hemolytic uremic syndrome, thrombotic thrombocytopenic purpura. This can be a complicated concept to understand, but I will tell you a simple way to understand. There is something wrong with the capillary endothelium. Now, this could be due to infection, it can be triggered by some autoimmunity, it can be triggered by severe hypertension. When there is degeneration or damage to capillary endothelium, below the endothelium, the subendothelial connective tissue is prothrombosis. So platelets come into contact and form microthrombi at various areas of the circulation, especially the small vessels and capillaries. What happens is this leads to platelet plugs. Now, small vessels are small in diameter, and when they are occluded by platelet plugs, the RBCs have to squeeze through it. While squeezing, they get sliced. This leads to hemolytic anemia. RBCs contain SGOT within it, and RBCs contain LDH within it. So the moment they get lysed, LDH and SGOT will go up. The heme which is exposed binds to haptoglobin and hemopexin. So haptoglobin and hemopexin will come down. And what you will get is anemia. You have already used up platelets everywhere. So there will be thrombocytopenia. There will be increased blood pressure. Now blood pressure, there will be increased creatinine. So blood pressure increase can trigger this, and blood pressure can be increased due to acute kidney injury as well. So if you do peripheral blood smear examination, you will see fragmented RBC or cystocytes, thrombocytopenia, raised LDH, decreased haptoglobin, increased SGP. Urine is positive for heme, not for hematuria. Not RBCs are not there in urine alone. There is heme leaking out of the RBC also. So your dipstick is positive, protein positive. You will have granular cast and RBC cast because all this clogging happens in capillaries. And where are the capillaries situated? Within the glomeruli. So it's very important to know this. Now, treatment I'm not going to go into. Very important to understand that you give supportive treatment, but there is a role of plasmapheresis in these subset of patients because there is some immunological factor which has triggered it. You treat. If there is an accelerated blood pressure, you control the blood pressure. Now, glomerulus. Now, glomerulus can have two types of affliction: nephrotic syndrome, nephritic syndrome. Go back to your pediatric class. Nephrotic was classified as nephrotic syndrome. Baby child used to have more than 3 grams proteinuria. Because proteinuria was too much in the urine. There was swelling up of the body, anasarca, because albumin used to fall down. Because albumin used to fall down, liver started working more, trying to compensate for the low albumin, and liver also makes VLDL. So hypertriglyceridemia, hypoalbuminemia. But very important, because to non-damage to the glucose, there are with a charge like minimal change disease, protein is leaking out. There is no RBC in urine. It's just high grade proteinuria. Can it be primary? Yes, we know that the primary glomerular diseases are known. It could be associated with many other secondary to a disease as well. It could be associated with hepatitis B. It could be associated with what do you call HIV. It could be associated with some drugs, especially D-penicillamine. So there are many causes of secondary nephrotic. Very small fraction of diabetics too have nephrotic syndrome. Okay, so this is very easy to diagnose. The only problem is it does not present much with acute kidney and there is no oligonuria or anuria. But in old patients, when nephrotic syndrome occurs, it may present with rising creatinine. The only way to distinguish strong proteinuria in dipstick as well as in 24-hour urine protein estimation. Then comes nephritic syndrome. So what does nephritic syndrome mean? This is very important. This, in short, is the essence of the lecture. Nephritic syndrome patients have severe hypertension, sharp rising creatinine, proteinuria, immature. You are not quick in diagnosing patients with nephritic syndrome. Many of these nephritic syndrome patients have something called RPGN in their kidneys, rapidly progressive glomerulonephritis. And if you do not get a biopsy early, if you do not get high dose of cyclophosphamide in early, this patient from a reversible acute kidney injury within a matter of a week or so will become a chronic kidney disease. And you know how bad the life of a chronic kidney disease patient is. And a young patient, if you if you do a biopsy early, cyclophosphamide is given early, immediately, like magic, the creatinine increases and the patient goes. This is the only important thing that you need to learn, which I learned in my first year MD medicine, is whenever there is a acute kidney injury, please do urine. Whenever in the urine there is proteinuria and RBCs, then you please suspect nephritic syndrome. Actually, there are two types of RBCs. You can have proper RBCs or you can have deformed RBCs. Now, whenever the deformed RBCs are called casts, deformed WBC called WBC cast. So what happens whenever there is a problem in the glomerulus, the RBCs are pushed out, squeezed out, deformed. They are deformed RBCs, but normal microscopy will and inexperienced pathologist will not be able to tell you whether it's a RBC or deformed RBC. You have to send for phase contrast microscopy, which tells you whether it's RBC alone or an RBC cast. But at a primary level, moment you have seen proteinuria, you have seen hypertension, you have seen RBC in urine, you know that you are dealing with possibly RPGN. Immediately order for phase contrast microscopy or go. And the moment phase contrast microscopy shows crenated RBCs, immediately do a biopsy. Biopsy will show crescents in the glomeruli, start the treatment, and get miraculous results. What are these systems? There are many systemic diseases associated with RPGN. So you should always examine the skin from head to toe. If you have dark red spots, you palpate that. You touch the dark red spots. If you can feel the dark red spot, it is palpable. It means that leukocytes have adhered to the wall of the small vessels and have blocked it, and that's how you can feel it. It's like your thrombosed vein. Like that. Lower limb examination. Lower limb has got palpable purpura. If there is palpable purpura, please understand that there is a leukocytoclastic reaction. That means this patient is having an autoimmune phenomenon. You please rule out Church straws or microscopic polyangiitis, etc., etc., etc. Okay, not slow in purpura. Arthralgia, joint pains, because immune complexes get deposited in joint. It's called a type 3 reaction. It's going to cause joint pain. There could be fever. There could be cardiac murmurs because infective endocarditis may also lead to this. Sinusitis, very important. Depressed nasal bridge is seen in leprosy and vaginers. If you see somebody's nasal bridge depressed, please think that this is sinusitis associated with kidney involvement. This is vaginal granulomatosis, or nowadays it is called as granulocytosis with polyangiitis. Very dangerous disease. You get nodular lesions in the CT, in the chest. You get rapid glomerulonephritis. And one blood test diagnosis vaginers is C ANCA. You get C ANCA, don't even do the biopsies, start immunomodulation. Is important, abdominal pain is important. What is and neuropathies? Neuropathies are known with Churg-Strauss and with microscopic polyangiitis. So all this you have to cover in the physical examination. Hemoptysis with acute kidney injury, it can be either vaginers or good pastures. You will what kind of hemoptysis they have. They can cough out 2 to 3 liters of blood and die. The only way to save them is IVIG or exchange plasma transfusion. Very important to know these patients. I once intubated a patient and kept suctioning. The entire suction bottle filled up, but then the patient died in spite of giving. So pastures by kidneys also and can use the lungs also as a mode of death. Very dangerous. Is decreased lupus nephritis, post-lupus glomerulonephritis, membranous glomerulonephritis. These are complement activation and cryoglobulin. There are 3 types of RPGN. There, whenever you do biopsy, you get crescentic involvement of the glomerulus and you get linear you can then you immune complex, immunofluorescence. If you get linear deposit along the basement membrane, it is good pastures. If the lung lesions are there, it is renal-pulmonary syndrome. If lung lesions are not there, it is called as renal limited good pastures. If you get lumpy, bumpy granules, then it could be acute post-infectious glomerulonephritis. If you remember from your memory, acute post-infectious glomerulonephritis happens 1 to 3 weeks after a sore throat. But sometimes our patient may not remember the sore throat. Again, more importantly, more than sore throat, you get lesions on the skin. You get what do you call erythematous lesions on the skin, which are due to streptococcus, and streptococcal erythematous lesions will lead to all these what do you acute post-infectious glomerulonephritis. Lupus nephritis, you know SLE diagnostic criteria. It's very simple. Infective endocarditis, I always told you to listen to murmurs. Immunoglobulin A glomerulonephritis, please understand, this is a very important concept. This is very strange. IgA glomerulonephritis can produce RPGN also and can be absolutely benign. Most common cause of hematuria or blood in urine all around the world is IgA nephropathy, and it happens classically after some upper respiratory tract. 2 3 days ago, he had upper respiratory tract infection, suddenly started passing urine. If the creatinine doesn't go up, just keep monitoring creatinine, it's fine. If the creatinine starts going up, suspect there is something going on in the kidney itself, and then you may go ahead and do a biopsy. Henoch-Schlein purpura is nothing but IgA glomerulonephritis with lesions, palpable purpura in the buttock region, and also diarrhea and pain in abdomen, because the small vessels of the buttock as well as GI tract get involved, membrane and cryoglobin. So there are type 1 disease is good pasture, type 2 is having granular immune deposits. These are the list. And there is a type 3, where in which there you will never find any immune deposits and yet you find crescents. These diseases can be separated into Wegener's and non-Wegener's. Simply by, that's why I've kept Wegener's in blue. These are C ANCA positive and the red ones are P ANCA positive. Okay, so individual polyangiitis, Churg-Strauss will have eosinophilia, idiopathic crescentic. As you know, idiopathic means whenever you put idiopathic, you don't know much about it. But all of them, luckily, respond very well to immune suppression, high dose steroids and cyclophosphamide. Okay, so the bottom line is patient with proteinuria, raised creatinine, oliguria, RBC cast is suspected to be RPGN. Please do renal biopsy urgently. Give immunomodulator therapy to prevent CKD. The next is interstitial disease. So we have covered large vessels in renal arterial thrombus, renal venous thrombus. Small vessels may HUS, TTP, and atheroembolic disease. We covered the glomerulus in the form of nephrotic and nephritic syndrome. I'm not going into details of individual diseases, otherwise this will be a 12-hour class. And then we come to interstitium. Interstitium is what lies between the tubules and glomeruli in the kidney. Now what happens is this interstitium is basically loose connective tissue. So it can get infiltrated by leukocytes and monocytes and eosinophils. Here is where the allergic association of kidney injury occurs. So most important interstitial nephritis can be provoked by antibiotics like methicillin, cephalosporin, rifampicin, sulfonamides, erythromycin, ciprofloxacin. So while rifampicin is not nephrotoxic, some patients can be allergic to rifampicin, and that can cause acute kidney injury. We have seen many patients of rifampicin-induced AKI. Sulfonamides less used, but you can still get it. Erythromycin is common, ciprofloxacin is common. Again, diuretics itself can cause acute kidney injury. So you have to be very careful. Furosemide, thiazide, chlorthalidone, and anticonvulsant medications like phenytoin, carbamazepine, and allopurinol. Allopurinol is very important because allopurinol, when it causes interstitial disease, it also causes rash. So if you get a rash in the body and you have a use of allopurinol history and you have a rise in creatinine, you for certain know that this patient has interstitial disease. Generally, interstitial disease is associated with rise in creatinine, but not much decrease in urine output. Urine is coming out, but creatinine is high. Why? because it afflicts the nearby tubular cells and the excretion, active excretion of creatinine is inhibited. And tubules are mainly for reabsorption of fluids. So all the glomerular filtrate gets excreted. Like Staphylococcus, Streptococcus, cytomegalovirus, and Epstein-Barr virus related. We don't even diagnose it. I have never seen it. I'm just completing the list. Tuberculosis can cause everything. So forget it. Okay, NSAIDs are important, anticonvulsant drugs are important, allopurinol is important, antibiotics like cephalosporins are important, rifampicin is important, erythromycin and ciprofloxacin are important. What happens is, how do you establish whether this patient is having allergic interstitial nephritis? Generally, you have varying history. NSAIDs on an average need to be used for 6 months to cause allergic interstitial nephritis. If NSAIDs cause an acute rise in creatinine, it is because of the previous pre-renal intrarenal hemodynamic theory. If NSAIDs, long-standing NSAIDs, and there is no decreased urine output and still there is a rise in creatinine, then it can be allergic interstitial nephritis. Other medications, 2 weeks. Fever, rash, and flank pain are very important. Laboratory investigation may eosinophilia, especially seen with allopurinol and penicillin derivatives. Again, maculopapular rash and petechial skin eruptions can be seen in penicillin derivatives and allopurinol. Urine, I told you, RBC casts are found in glomerular problem. WBC casts are found in interstitial nephritis. If you get WBC casts, you for sure know that there is a problem in the interstitial. And very important, staphylococcus can cause UTI in this manner. It can cause interstitial nephritis and therefore can cause WBC casts. Okay, so this is very important to note. That's why even isolating one staph is enough to diagnose a patient of UTI. Urine is typically isotonic. 20% patients are isotonic because it's same as plasma because of the dysfunction of the neighboring tubular cells. 20% of patients are oliguric. Most patients are not. There can be a huge nephrotic range proteinuria in NSAIDs. In the causes of nephrotic syndrome, I forgot to mention NSAIDs as a very important cause of drug-induced nephrotic syndrome. Okay. Uh, okay. And eosinophils, earlier they used to emphasize upon eosinophils for diagnosing allergic interstitial. Whenever there is allergy, you try to search for eosinophils somewhere. But we found that it is present in less than 40% of patients, and mostly it used to be present in methicillin-induced acute kidney injury or allergic interstitial nephritis. As you know, methicillin is banned because of the adverse effects and very, very high incidence of allergic interstitial nephritis. But it was classically described. So it has persisted in textbooks, but you won't find it. Okay. Now we go to tubules. Now tubular necrosis means damage to the tubular cells. This could be ischemic, it could be toxic. What does ischemic mean? I told you that if you neglect pre-renal causes, then you get tubular damage. For a long period of time, person has had diarrhea or person has had decay, and that decay has been neglected all over for 24 or 48 hours. You have not given adequate amount of fluid. The kidney perfusion has suffered for more than 24 to 48 hours. That is when what will happen is the perfusion of the kidneys and perfusion of the tubular cells will decrease. And the tubular cells will start having necrosis and fall off into the tubular lumen. This is called ischemic tubular necrosis. And at that stage, even if you give fluids, the patient will not have an increase in urine. That is why whenever you get diarrhea patients, immediately stop nephrotoxic medication and start giving fluids properly. If you don't, the pre-renal goes into ATN. And ATN, pre-renal has a mortality of less than 1% and ATN has a mortality of 20 to 50%. That's why it's very important to prevent ischemic ATN. Again, the same analogy holds true for vomiting, the same analogy holds true for decay, the same analogy holds true for pancreatitis, burns, cardiac failure, and sepsis. Sepsis also causes ischemic ATN because sepsis causes peripheral vasodilatation. Sepsis causes bad cytokines which interfere with intrarenal hemodynamics. As a result, and sepsis causes increases in the demand, oxygen demand of tubular cells, and therefore it can cause ischemic ATN. there are some drugs which are toxic to ATN. So this list is toxic ATN, means drugs which are directly damaging the tubules. So aminoglycosides, amphotericin B, pentamidine, foscarnet, acyclovir, indinavir, antineoplastic agents like cisplatin, gentamicin. So remember aminoglycosides. So that is gentamicin is aminoglycosides only, and amphotericin B and cisplatin. These are the three big ones. Pentamidine you would have hardly used because if you are not treating only HIV patients, then you don't use much of pentamidine. Foscarnet, CMV infections, yes. Acyclovir is very common. Again, you should not forget. Indinavir nowadays is not used. Mostly ritonavir-based regimens are used for HIV. Radio contrast dye is important because we use radio contrast dye in everything. CT, CT angio of the brain, CT angio of the pulmonary artery, CT angio of the aorta, CT of the renals, everywhere. Yeah. Cardiology, we are using contrast day in and day out in the coronaries, within the ventricles. And I will tell you a bit about radio contrast dye. How does it present and what can we do to prevent this kidney damage? Organic solvents like carbon tetrachloride, I don't know which industry they use it in. Ethylene glycol is used in the Western world where temperatures are very less. That's why to make sure that the engine doesn't freeze. So ethylene glycol poisoning, if you are moving to UK, you will get to see that. I've never seen it in India, but it causes a very interesting sort of a urinary crystal. That is a question for you guys to put it up in the WhatsApp group. Anesthetics like enfluorine, again, out of favor because of acute tubular necrosis. Oral sodium phosphoda, used for bowel preparation before colonoscopy, can cause acute phosphate nephropathy, resulting in acute nephrocalcinosis. Very important. Sometimes you have to be very careful. You have to explain it to them. Myoglobinuria, hemoglobin, can also cause what do you call tubular damage. So, in patients who have neuroleptic malignant syndrome and serotonin syndrome, etc., there can be, because of excessive contraction of muscles, there could be leakage of myoglobin in the blood. This myoglobin gets filtered and it damages, oxidative damage. Similarly, hemoglobin itself, because of incompatible mismatched blood transfusion. If anybody remembers, the first symptom of mismatched blood transfusion is chills, rigors, and loin pain, because that hemoglobin gets stuck in the tubules, causes a stretch, and therefore you get loin pain. If a patient who has been transfused blood suddenly complains of decreased urine output and loin pain, you know that this is a cause of what do you call acute kidney injury. How do you take care of it? If you know that there is myoglobin production, increase hydration so that you flush it out, and there is something called you can add in bicarbonate, it gets dissolved and gets excreted out. Uric acid, acute uric acid nephropathy. There are three ways in which uric acid involves. Uric acid itself can cause interstitial nephritis, it can cause tubular toxic damage, and so the uric acid we will deal with separately. There is acute and chronic uric acid damage to the kidneys. Both have to be seen. Now, contrast. Now, before if you have a patient who is to be administered contrast, how do you know what is the risk of him getting an increase in creatinine due to the contrast? First and foremost is pre-existing renal function. If his EGFR is less than 60, you know that this patient is going to need it. I would say all the guidelines say stop metformin if GFR is less than 45. If GFR is less than 60, stop metformin for 2 days and then do the investigation using contrast. You know it's you know that it is very likely the diabetics would get it. How do you prevent it? Only one powerful weapon you have. Hydrate the patient. 1 ml per kg per hour for 12 hours before your CTPA or angiography or any contrast needing procedure, and after it continue for 24 hours and monitor the urine output. Interesting thing is contrast induced nephropathy does not happen immediately. It takes 48 hours minimum to 7 days for it to manifest. Therefore, repeat creatinine at 48 hours, 5 days and 7 days later. NAC N-acetylcysteine, one drug with many applications. It is used in fulminant hepatic failure. If you remember, we have used in a couple of patients. It has been tried, but the results have been um, ambiguous. The recent preserved study showed that there is no benefit, but there is no harm as well. So give it. Monitor urine output after contrast. Use low or isoosmolar contrast. The low osmolar contrast is less than 800 milliosmoles. Isoosmolar is around 800 to 1600. More than 1600 is high osmolar. So try and use low or isoosmolar contrast. There are many dye names that are there. You can ask the CT radiologist. Don't use Omnipac. Use Visipac, which is only 270 milliosmoles. So we do it in cardiology whenever we have a patient whose creatinine is slightly raised and we have hydrated him, we have used low or isoosmolar contrast. These are the urinary findings in various causes of AKI. This is a golden table. Remember it. It will help you everywhere. So I have encircled what is important. There is a pointer. Okay, I'm not getting the pointer, but extreme right acute tubular necrosis is characterized by granular cast. Granular casts are nothing but tubular cells which have been damaged. Granular cast and renal tubular cells. If you see them, you know that there's a tubular injury. I told you that it is basically the tubules which help in reabsorbing and concentrating the urine. If the tubular cells are damaged, patient will pass dilute urine. You would get interstitial cells, interstitial nephritis, WBC casts, less amount of RBC casts, but RBCs you will get, WBCs you will get, but you will not get RBC casts, you will get WBC casts. Okay, if you get that, you know that it is acute interstitial nephritis. You will get proteinuria. In acute tubular necrosis, you never get proteinuria because protein secretion is the function of glomerulus, and you only get in acute interstitial nephritis because the leukocytes lies and they release the proteins. Okay, so heme is present, proteinuria is there, leukocyte esterase because is also a very important thing. Leukocyte esterase is present in acute interstitial nephritis and it is also present in bacterial involvement or UTI. Nephritic patients, I told you, presence of heme, presence of protein, presence of RBC casts. Very dangerous patients, evaluate fast, less 1 to 2 gram proteinuria. Nephrotic syndrome, everything is bland except for protein. Pre-renal, nothing you will get. No RBCs, no proteins also. Only you will get a concentrated urine. Okay, and this is very important, specific gravity. Now, most of the centers don't do urinary sodium, urinary osmolarity. You have to specially send it. It is sent to an outside laboratory. It takes about 48 hours to come. Specific gravity is high and you are suspecting pre-renal and there is no protein and no RBCs and no heme on the dipstick, you know that it is pre-renal. Specific gravity is low, then it is post-renal or something wrong with the tubules. Because post-renal also causes damage to the tubules indirectly, a malfunction of the tubules because of the pressure. And acute interstitial nephritis and acute tubular nephritis both cause damage to the tubules. Tubules are damaged, your concentration will not be there. And when this concentration will not be there, you will pass dilute urine, your specific gravity will drop. The same is the case with chronic kidney disease. Chronic kidney disease is associated with fixed specific gravity. The patient during dehydration cannot increase the specific gravity, that is during dehydration cannot pass a more concentrated urine. During overhydration cannot pass a dilute urine. Because all this is a function of intact glomerulus and intact tubules. If both are damaged in chronic kidney disease, you will not be able to do either of them. You are just going to pass fixed specific gravity. Okay, so this table you can keep in mind. Post-renal, I don't want to utter much about it. I think we went through the causes earlier. Just very important is ask for history of abdominal surgery, check for pelvic malignancy. Every female who has acute kidney injury, do a pervaginal examination and a pelvic examination to rule out any malignancy. So they can sometimes present with advanced malignancy, which can lead to obstruction of urine. Okay, so that is done. Stones and blood clots and pyogenic debris, slough papillae, uh, all these can cause. Blood clots are especially important because they can get stuck into the bladder outlet obstruction. Very interesting. In hematuria, whenever due to maybe anticoagulation or due to heparin, you should never use tranexamic acid because that leads to blood clot formation in the urine. And this blood clot goes and obstructs the bladder neck. And this can cause acute kidney injury. Therefore, never, if hematuria is occurring, don't ever use tranexamic acid. Okay. So, what is the management? Now, the $1,000,000 question is management of AKI. By now, we have established the diagnosis of pre-renal. Pre-renal, first step in management of all AKI is review the drugs. ACE inhibitor like ramipril, enalapril, perindopril, lisinopril, sab band. ARBs like telmisartan, azilsartan, sab band. Metformin band. Clexane stop. Tamiflu stop. Some cyclosporin, tacrolimus, everything stop. Then once you have stopped the ongoing damage to the kidney, hydration status, start hydration. Young patient, you can go high. You can give 500 ml over 2 hours of ringer lactate or normal saline. Ringer lactate is marginally better than normal saline. Don't ever give D5. You are not hydrating because when you give 100 ml of normal saline, around 300 to 500 ml gets retained in the vasculature. Whereas when you give 1 liter of D5, only 100 ml gets retained in the vasculature. So D5 has only one application. Sometimes it can be used to carry the drugs, or like what do you call isoprenaline is diluted in D5, and D5 is also used for hypernatremia. Otherwise, there is no function of D5. So don't use D5. Surgeons especially are famous in using D5. Send electrolytes immediately, creatinine, blood urea nitrogen, venous blood gases, do a quick USG of kidney, do urine dipstick and microscopy. This is the minimum that you must do. Hydrate in aliquots of 500 ml until there is adequate urine output. So when you are hydrating, keep checking urine output. Your target is 200 ml per 2 hours and continue it. Once you have started, the urine output has started to flow and you feel that JVP has returned and the patient is lying down. That means the hydration is adequate. Now, don't worry about the CIM creat. You just chase the urine output. Urine output plus 500 ml fluid you should give the patient. It can be orally, it can be through IV. If the patient is if the patient is either not very conscious, then you might give IV fluid. If the patient is conscious, healthy, hale and hearty, you just tell him you are passing 800 ml of fluid, 800 plus 500, 1300. You please drink 1300 ml of fluid. The advantage of oral fluid is even if it takes a little extra, the body will take whatever it needs. So that's very important. But there is one more problem. Suppose when the patient's kidney recovers, sometimes there is a tubular damage, and tubular damage recovery can cause polyuria. So patient can pass 3 liters. Now very few patients can drink 4 liters of water. So then you partly supplement by IV fluids and partly supplement by oral fluids. Intrinsic kidney injury, that means something the problem is within the kidneys, can be so two types: one with fluid overload, one without fluid overload. Fluid overload means JVP is seen even when the patient is erect, patient is breathless. On auscultating the chest, you find creps, patient has pedal edema. So, and if you do echo, then you see the distended IVC. First is to put Foley's or a condom catheter and attach it to a Euroflow meter. Euroflow meter is a special urine Foley's bag with a small chamber attached to it, which will help you to measure hourly urine output. Send electrolytes, creatinine, BUN, VBG, USG, kidney, etc., dipstick, microscopy, like previously. If the BP is more than 100, dissolve 400 milligrams of Lasix in 100 ml NS and give 10 ml per hour infusion. Wait for 2 to 4 hours. If urine output is less than 200 ml in 2 to 4 hours, that means your Lasix furosemide challenge test has failed. Please refer for hemodialysis. That means that it is not going to work with diuretic alone. But most patients suddenly start passing out urine, and they start passing urine quite good quantity. Why is it so? because the forceful nature with which you diuretics will push the fluid will make sure that all the acute tubular necrosis slough which is blocking the tubular lumen is flushed out. Okay. Second thing is, theoretically, Lasix inhibits the absorption of sodium in the ascending thick loop of Henle, and because it is an active process, it decreases the oxygen requirement and therefore helps in preservation of the cells. So that is intrinsic acute kidney injury with fluid overload. Intrinsic acute kidney without fluid overload. Well, again, like even this also, stop nephrotoxic medication is the first. Again, it's similar. Now here, without fluid overload, you have not seen overt fluid overload signs, but you know that this patient might develop fluid overload when we give too much fluid. So you give 200 ml and then give 40 mg Lasix, see what happens. Nothing happens. Again, another 200 ml and give a little bit of 20 mg Lasix this time and keep auscultating. 6 hours, if you keep doing it and there is no urine output, then you raise an alarm that yes, we cannot, this patient is probably going to need hemodialysis. Nutrition, well, adequate protein intake is very important. Now, this is myriad. Some people just have pre-renal acute kidney injury. Please give them proteins. There was a time when it was felt that creatinine is rising, BUN is rising, so decrease proteins, restrict proteins. This will help in decreasing creatinine. This is actually defeating the moot point, and therefore it was later discovered that you have to give adequate protein supplementation for best outcomes. So 0.8 to 1 milligram for 1 to 1.2 milligram proteins for patients who have pre-renal and intrinsic renal. Patients who are needing dialysis need more proteins, and patients who have sepsis with acute kidney injury may need proteins to the tune of 1.7 grams per kg. And more than 50% of it should be first class protein. What is first class protein? Vegetables, legumes, I'm sorry, the vegetarians, they are all second class protein. The only first class protein are eggs and meat. So there was again a thought process that meat will cause more uremic encephalopathy. It is wrong. Again, coming to this concept, every acute kidney injury patient must be assessed for uremic encephalopathy. That means abnormality in brain function due to uremia. How do you do that? Ask him for time, place, person. Time, place, person, if he can tell accurately. Then you ask him to extend his fingers like this, all 5 digits fanned out and extend it. And if it starts falling down in jerks, it's called flaps. If flaps are present, this patient has uremia. Don't waste time. Do dialysis fast. Okay? Because after this, he may throw uremic seizures. One more thing that you need to auscultate for is uremic pericardial rub. If you get a leathery scraping sensation on auscultation in a patient with raised creatinine, you have to call the nephrologist for the dialysis. So these are the, in nutshell, the indications for dialysis. We call it renal replacement therapy because dialysis is a complex terminology which includes peritoneal dialysis, hemodialysis, continuous veno-venous hemodialysis, hemodiafiltration, filtration, etc. That is a different topic altogether. Refractory fluid overload, more than 6 hours of adequate urine treatment, as we had said. If the urine output is still inadequate, refractory fluid overload, you are giving diuretics, patient's pulmonary edema is still there, patient is breathless, patient has Krebs. Refractory hyperkalemia after hyperkalemia correction that we have already talked about in our DK lecture. If that also doesn't cause fall in potassium, because ultimately where the potassium will go? It has to go either in the stools or in the urine. If there is no urine production, where will the potassium go? It can only go inside the cells. But even if the inside of the cells are saturated, then it cannot go anywhere. So the only way to do it is dialysis. Uremic pericarditis, altered sensorium with flaps, severe metabolic acidosis, pH of less than 7.1, and bicarbonate of less than 12 milliequivalents, BUN of more than 100 milliequivalents. This is a soft indication for renal replacement therapy. Thank you. Do you have any questions? Hello? Hello? Hello?
Yes, sir.
Do you guys have any questions?
No, sir,
Ask
no
a few.
questions.
Was it easy to understand or was it difficult?
It was amazing, sir, especially the treatment in segregated categorical way. Thank you so much.
All right. Any comments? Any particular subset of patients that you find difficult? I'm sorry for the grammar, the spelling mistakes because the original PPT that I had prepared for you guys, I somehow did not save it this afternoon, and to my horror, I found that it got deleted. So I had to
Sir,
make this PPT over the last 3 hours, 3 or 4 hours. Yes.
So I had one question. In
Uh,
Wegener's granulomatosis, is it possible that the kidney damage will happen before manifesting any other symptoms, like in gums and all?
yes, yes. And that is what is called as idiopathic Wegener's or Wegener's renal what do you call limited Wegener's. That is
Oh,
why I keep
okay.
telling you that you must send C ANCA and P ANCA. So C ANCA will be positive in 90% of Wegener's.
Okay, okay.
Okay, and if there
Yeah,
is an acute kidney injury which is fitting into nephritic syndrome, you send compliments, you send C ANCA, P ANCA before
yeah.
biopsy also. You will get a great
Compliments
idea.
for lupus.
Compliments for, I told you, na, the diseases in which compliments are raised.
Yeah,
Lupus nephritis, yes. Wegener's granulomatosis, no. But there are this membranous proliferative glomerulonephritis, etc. I'll go back
yeah.
to that soon, I guess. Anything else?
Yes, sir.
Anybody has questions? If there are no questions, then I'll log out. Okay.
Yes, sir. Thank you so
Uh,
much, sir. Thank you, sir.